okay?
Yes.
Awesome, wonderful. So hey, my name's Taylor. I am an administrator with the Department of Health and Human Services. I work in the Office of Substance Use and Mental Health on the opioid treatment team. Yeah, really happy to be here today. Rachel, thanks for having me. If there are questions or comments as we go through this, let me know. I just want to make sure everyone can see this okay. I do have like the video like pulled up with the PowerPoint, and I don't want to like be duplicating screens for anybody. Cool, awesome. All right, so I'm going to talk today. Typically my training lasts about 45 to an hour, but I know I have about 30. So I'm going to parse it down a little bit. If there are questions or concerns, or if people have thoughts, Rachel, would you mind watching the chat, or please unmute yourself? Really encourage discussion. But today, I'm going to talk a little bit about how our attitudes and perceptions can really impact substance use and recovery. So an opportunity to create some awareness about how stigma might affect substance use disorders, mental health, and access to people's treatment. So we're going to talk about substance use motivations. Oh, okay. Substance use motivations and how the chronic disease of substance use disorder can sort of originate and develop. I feel like that's kind of a review for a lot of people. So then talking about stigma and identifying negative effects through our interpersonal systems level interactions, strategies for identifying and avoiding stigma surrounding substance use and substance use disorders, some negative beliefs, so like the common myths and misconceptions surrounding MOUD, and then just wrapping it up with recovery and its elements. So substance use motivations, there are multiple reasons why people start engaging in substance use and multiple reasons why people continue. So I feel like this is going to be a big review. So I'm just going to kind of cruise right through it. So the first is to feel good, right? Those feelings when using substances, drugs, alcohol, things like that, provides feelings of pleasure, euphoria, relaxation. Sometimes people use substances for energy. I drink coffee every morning. That's a stimulant. To feel better, coping mechanisms, right? We manage stress and anxiety, depression, or co-occurring disorders through substances. And then this is pretty relevant for teens and adolescents, curiosity and social pressure. Like, what does this do? My friends are doing it. Other people in my community are doing it. What does this do? So there are, those are some reasons, right? Motivations. But like digging a little bit deeper about why people might begin to use substances, we have trauma, especially in early adolescence and things like that. And I'll talk a bit more about ACEs. Mental illness being a risk factor for substance use. We know that 1 in 4 adults here in the United States are living with a serious mental health problem, also have a substance use disorder. And then, that self-medication. So symptoms of mental health disorder, chronic pain, other depression, anxiety, things like that. So ACEs, these are things, again, feel like this is probably a review for this crowd, but adverse childhood experiences. These are traumatic events that occurred from 0 to 17 years old. These are things like neglect, abuse, having incarcerated family members, household challenges like domestic violence, divorce, things like that. Other things that we should really be considering are not having enough food to eat. So food insecurity, right? Experiencing homelessness or unstable housing if you're moving around a lot, or even like experiencing discrimination, especially, again, growing up in different school settings amongst your peers. We know that ACEs put people at a risk of health, social, and emotional issues and are strongly associated with the development of substance use disorders. So with each added ACE, we see that individuals are 2 to 4 times more likely to report early initiation of substance use. And we know that with each added ACE, we see more serious problems associated. We know that people with an ACE score of 5 or higher are 7 to 10 times more likely to report illicit drug use compared to those with an ACE score of 0. So kind of interesting. And so it just kind of drives home the impact of trauma when we're talking about substance use. And so we know that it's cyclical, right? So trauma is a risk factor for substance misuse. Substance misuse is a risk factor for trauma. People who are already misusing substances may be less likely or able to cope with a traumatic event, and people can develop substance misuse issues to manage distress associated with the effects of traumatic stress exposure or traumatic stress symptoms. So kind of reoccurring issues there. Okay, that was really, really brief overview, kind of setting the stage about like the possible why, right? I'm going to talk a little bit about the what. So stigma itself, again, I feel this might be a review for some people, and then we'll go into a bit more of the practical, practice of the training here. So when I was putting this training together, I was looking at the definition of stigma, and it kind of stumbled upon like this Greek origin, where it refers to stigma being like a tattoo or marking, stigmata, that was cut or burned into the skin of criminals or traitors, slaves, things like that. That mark was used to designate these people as blemished or, to prevent other people from associating with them. So in more academic, more modern terms, we still use stigma as an attribute that is deeply discrediting, right? It's still associated with that, social rejection and status loss. We still label people, discriminate, things like that. I like to think about ways that we can view stigma, and the first is through this lens of fault and control. When we think that someone is ill or sick through no fault of their own, or that they have minimal control over their illness, neither the person nor the illness is generally stigmatized. On the other end of this spectrum, if we think that an illness is within someone's control, or at least partially their own fault, we tend to attach stigma to the person and the illness. And so substance use disorders are often viewed in that latter light. The effect is then compounded when someone is using an illicit substance, because there's that added association of criminality, right? We've all seen communications in different media forms, outlets, things like that, that exemplify this point. Oftentimes, media spaces take pains to point out that the first opioids were taken to treat an injury, and oops, maybe the doctor overprescribed. So it reduces
the doctor.
Yeah. So, but it reduces the perception of fault, whereas a person who developed a substance use disorder via illicitly obtained substances may be perceived more at fault. And so we see here just at the bottom of the screen, like a spectrum where some people with an illness may be considered more at fault than others. Just things to start thinking about. The other helpful way to examine stigma is to differentiate between internal stigma and external stigma. So this internal stigma, it's the self-stigmatization, it's the internalization of negative social perceptions. It involves a big sense of shame and the expectation of discrimination from others. This expectation of discrimination can actually prevent people from seeking help. And we know that people who experience stigma often use and maybe even deplete their emotional regulation strategies to cope. And so this can reinforce maladaptive coping behaviors. So people who are experiencing stigma related to substance use may turn to substances as a coping mechanism for experiencing those stigmatizing feelings, right? We know with empirical data that stigma is associated with lower self-esteem, higher depression and anxiety, and poor sleep. The other lens is external stigma. And so this is taking form of discrimination towards a stigmatized person. It can be on an individual level, so person to person, so rejecting a job application, refusing to rent someone an apartment, things like that. But then we have this structural level, right, that encompasses the disadvantages that arise out of that interpersonal or individual model. And then we see institutional practices or other policies that really start to exacerbate these disadvantages. One example of external stigma that comes to mind that starts as individual and then can be exacerbated into structural is stigma against people who've experienced an overdose and who have been revived by naloxone. So there are individual attitudes of discrimination. So individuals might say that they don't think that someone deserves to be revived, right? They've made their choices, their overdose is their problem, and I don't think they should be revived. So that's an individual external level of stigma and discrimination. But then if you have these individuals who have the ability to make policies, then we see larger levels of systematic stigmatization and discrimination. So this could be like police departments or other first responders refusing to carry naloxone because of these systematic discriminations and stigma. Okay, I just breezed through those first two sessions. Wanted to check in, see if there were any thoughts or questions before I get into kind of like the how, kind of meat and bones, meat and potatoes. Okay, cool. Thanks for the thumbs up, Seth. Appreciate that. All right, so stigma and language. When I talk about potentially stigmatizing language, this is really important, right? I like to differentiate between a person's intention and the potential impact, right? They're two separate things. A lot of the times, the words that we are using are inherited. They're really commonly used in our social settings or even in therapeutic spaces used by individuals in the community themselves, right? So using those inherited words doesn't mean that you have bad intention, but we have the opportunity to know and learn the impact of potentially stigmatizing language, and then it gives us the opportunity to choose a new path and to have a more open discussion. So again, intent versus impact, common language. We know that using stigmatizing or negative language to describe people can have really negative impacts on their health. So something that we can do to identify and avoid stigmatizing language is to perform a language audit. So it's an opportunity for us to examine the language that we're using in speech, in our writing, and consider alternatives. So we'll have a little fun exercise coming up that we can practice something like that. So one great way to avoid stigmatizing patients, clients, I'm going to use the word interchangeably, is to use person-first language. So this is the linguistic style that puts a person before their diagnosis, right? Describing what condition a person has rather than asserting what a person is. So if you say that someone is an addict, you're implying that the person is the problem. You're labeling them, you're connecting them to stereotypes, discrimination, things like that. And being in a position of power as healthcare professionals, that's going to really affect the power differentiation and really reinforce that internalized stigma, right? So rather than using labels to define individuals with a health issue, it's much more appropriate to use terminology that describes individuals as being diagnosed with an illness or disorder. So again, putting the person before the diagnosis. So if you say someone has a substance use disorder or someone is living with a substance addiction, it implies that the person has an issue that can be addressed. So all of these components, again, really depend on this person level interaction, this individual level. Another way that we can go about things as healthcare professionals is using clear and technical language. So this really helps to avoid stigma and confusion by using clear technical language that has a single clear meaning, right? So when we're describing the results of a urine drug screen, some people may use the words dirty or clean, and that tends to conflate a person's drug use status with their cleanliness, right? A much more accurate and less value-laden way to describe test results is positive or negative, just like you would with any other medical test result. Right. So on the left here, I have a graph or a little chart list of some current terminology. Right? So we see addict, abuser, junkie, substance abuse, denial, relapse prevention, clean and sober, resistant to treatment. So again, these are really common words. Some may be used by patients or clients themselves. And this is where I like to pause and take a moment to recognize and acknowledge that, like, if people choose to describe themselves as clean and sober, or if they take on the label of addict, that can be really powerful for some people, especially in mutual aid settings, because they see that label as a constant reminder of their recovery journey. But in general, as healthcare professionals, we can choose less value-laden terminology when we are describing and working with people with a substance use disorder. here are some suggested alternatives. So again, instead of saying addict, it's a person with a substance use disorder. Instead of substance abuse, it's substance misuse or a substance use disorder. Instead of saying denial, they're ambivalent. Relapse, that's a big one for me. Again, much like any other chronic illness, I like to say recurrence or return to use. Clean and sober, drug-free, resistant to treatment, that's a very provider-centered worldview, right? So it's kind of taking the person first, the autonomy of our patients and clients. So they're choosing not to engage in treatment, right? Yeah, I think I kind of touched on all the points there. Any thoughts before we move on to our little exercise? Okay, so really simple exercise. I have 5 very short sentences. Hopefully it should just be a rather easy opportunity for us to engage and practice kind of a language audit, right? So part 1, I'm going to pop a sentence up on the screen, and I would ask someone, Rachel, I can't see the chat, but if anyone wants to unmute or use the chat, please identify if the sentence is stigmatizing, and if so, what about it is, and then offer a potential reword using less stigmatizing language. So first one, Paul is a substance abuser. Is this stigmatizing? I saw a nod. I saw some yes.
Yes.
Yeah. What about this is potentially stigmatizing?
Well, I'll answer. It's the word abuser.
Yeah. Yeah. The abuse, right? It has that really negative connotation. It aligns with like moral implications, things like that. Thanks for that. So how could we reword that to be less stigmatizing?
Paul has a substance use disorder.
Gorgeous. Thank you so very much. All right, next one up. Rachel's drug of abuse is cocaine. Is this stigmatizing? Or is this just talking about what's going on with Rachel?
It should be choice.
Drug of choice, yeah. And we can also, so the word abuse is what we're focusing on here as the potentially stigmatizing, right? Yeah, absolutely. It has that connotation with harmful behavior, immoral associations, that type of thing. So you could say drug of choice. Thank you for that potential reword. I would also just suggest saying Rachel uses cocaine. It's simple, it's clear, it's technical, it's to the point, it describes what's going on with Rachel, right? We don't need to say drug of choice, drug of abuse. It's not necessary. It's adding, extraneous information. All right, Kathleen has been clean and sober for over a year. First of all, shout out to Kathleen. You go, girl. Is this stigmatizing?
It doesn't take harm reduction into account.
Doesn't take harm reduction into account. What about the wording could be potentially stigmatizing?
Well, you said before clean,
Mhm.
saying that perhaps she was dirty before, so maybe just not using that word because it's associated with cleanliness.
Yeah, absolutely. So just talking about that again, Kathleen has not used drugs for over a year. Kathleen has been drug-free for a year. Clear technical language, right? We're not conflating drug use status with someone's cleanliness. And again, thinking about the words, we've inherited words like clean, dirty, things like that. So yeah, thank you so much. All right, 2 more. I promise we're almost through. Brian is non-compliant with his treatment plan. Oh boy, Brian. Is this stigmatizing? I see some shoulder shakes. And I understand that I'm talking to healthcare professionals. I do want to state that the term non-compliant is a very medically reasonable term, right? There's nothing wrong with that. And as healthcare professionals, as clinicians, using the term non-compliant in medical documentation is one thing. Using it with patients and clients is another, right? We don't want to use that with our patients because it could cause them to feel unmotivated, right? Like, oh man, I've not been following directions, reinforcing that internalized stigma. Like, I can't even do this right. So what's the potential reword for this? It'd be really simple. How about something like Brian has not been attending his treatment appointments? It explains what the situation is, the fact that, you know, there's something wrong with his treatment plan. It's not fitting him. He's not been going to his appointments, but it reinforces that he is a fully autonomous human who is capable of making his own choices. They might not be the choices that we have prescribed or that we agree with or that we support, and recognizing a patient's autonomy is really, really important. So saying something like Brian has not been attending his treatment appointments is significantly less stigmatizing than you're not following directions, Brian, you're not being compliant. All right, last one. Sally keeps providing dirty urine for her drug screens. Dang it, Sally. What about this is potentially stigmatizing?
It's the same thing with the clean and the dirty. You could just say Sally continues to test negative or I mean, test positive for her drug screens.
Beautiful. Thanks, Brandy. Exactly. Sally's urine drug screens have come back positive. Positive, negative. It's a medical test. You know, it does not mean that someone is dirty or clean. They're positive or negative. I can't drive that one home enough. And again, that's inherited language. It's not intentional, right? Two more things in terms of like language. Thank you everybody for participating in that. I know that virtual spaces are kind of hard to interact in. But nonverbal communication. So I think that this is a really important other strategy for recognizing and avoiding stigma is paying attention to our nonverbal communication. When I was putting this together, I learned that nonverbal communication can represent up to like 2/3 of all communication. And so when we're thinking about someone's tone, their posture, their face and body movements like eye contact or vocal tone, we know that poor nonverbal communication can reinforce stigma, and we know that it's associated with worse patient outcomes. But on the converse side, you know, if we have appropriate eye contact, encouraging vocal tones, open body posture, people are going to feel welcome. People are going to feel like they're valued, that they're in their right space seeking help and treatment. Oh yeah, physical proximity is the other thing. You know, if you're standing at the opposite end of the operatory or, you know, standing far away with your arms crossed, that's not going to make someone feel welcome or valued. And this one, it might not come up as frequently in your work, but I think it's really worth mentioning, is visual portrayals of people with substance use disorders, right? I know that I've seen media coverage of people, especially individuals who have been experienced an overdose. Sometimes police departments will share clear photos of these people with the media. So without verbal commentary, the sharing of these images without any sort of blurring of faces or whatever really sends a clear message that the privacy of people who have experienced an overdose, the privacy of people who are engaging in substance use is not a priority, right? It's that separation component. It's an us versus them, if you will. So this type of nonverbal communication can really have a tremendous negative impact, and it will compound both that internal and external stigma, right? Just continuously building upon it. So I encourage you in your work, in your space, in your day-to-day activities, just to be on the lookout for negative visual portrayals of people with substance use disorder, media, advertising, that type of thing. And something to keep in mind if you are developing any sort of client-facing or patient-facing literature. You know, I know that we have image portrayals, Adobe stock photos, things like that. But so sometimes those images are staged, right? But they're always an incomplete depiction of the subject. So just encourage you all to be on the lookout and a little more aware of that. All right, how are we on time? I got maybe 5 more minutes. So the next section, happy to run through it, Rachel, it's up to you. It's about substance use, about medications for opioid use disorder and some of the common myths and misconceptions surrounding it. Would that be beneficial for this space?
Yes, I think so, Taylor. Thank you.
Okay. All right. So MOUD, medications for opioid use disorder. We know that they are FDA-approved medications with counseling and behavioral therapies that can help people sustain recovery from an opioid use disorder. So they stabilize someone's brain activity. They reduce craving, strengthen coping capacity. They allow clients to focus on the behavioral therapies. We see increased periods of abstinence and self-efficacy. And then that leads to improved clinical outcomes, not just for the clients, but, you know, impact on family and loved ones and community. So amazing. This is one of the biggest, is this a misconception? What do we think? MOUD replaces one addiction with another. I hear this one a lot. Yeah, I'm seeing some other nods. Right, so it's a pretty common one. When I hear that, or when I'm talking to people that have that mindset, I like to, toss in what the definition of an addiction is. It's this repeated drug use despite negative effects on mental health, physical health, and interpersonal relationships. It's these complex interactions of brain circuits, genetics, environments, and individuals' life experience, things like that. Taking a medication that has been prescribed by your doctor to treat a chronic illness does not meet the definition of an addiction. We know that methadone and buprenorphine have gradual mechanisms of action where they're stabilizing the brain chemistry without producing the euphoria or leading to a crash. We know naltrexone blocks opioid receptors and is used after detoxification to prevent return to use. So we know with empirical data that OUD medications reduce cravings and the euphoric effect of opioids. So no, MOUD is not replacing one addiction with another. Next one, medically supervised withdrawal, AKA detox, is a form of treatment. I know that this one is really popular, especially in very abstinence-based states, locations, things like that. Sadly, we're going to dispel that myth as well. There is no evidence that detox programs alone are effective at treating opioid use disorder. It is not a treatment. It actually increases an individual's risk for return to use, overdose, and potential death without followed up with medications for opioid use disorder. Do we have a comment? So I do want to, acknowledge that medically supervised withdrawal can potentially be a great first step in substance use disorder treatment. But without any other form of treatment following it, it can really just increase the chance of overdose and possible death by lowering someone's tolerance. Okay, next one. MOUD is only intended for short-term treatment. 28 days in the treatment facility, we're out, we've cured it, right? Unfortunately not right. There is no one-size-fits-all treatment length or appropriate treatment length, right? According to NIDA, the length of a methadone treatment should be a minimum of 12 months. Some patients require long-term maintenance. Again, we're treating a chronic illness, that's potentially lifelong. The chronic nature of opioid use disorders really enhances the need for continuing MOUD, reevaluating it periodically, seeing how patients are doing with their treatment plans. There's no maximum recommended duration of maintenance treatment. And for some some patients, that treatment may continue indefinitely. It is up to us, it's up to the interactions with treatment providers and patients to discuss goals, right? How we want recovery to look like. Do we want to taper down? What it is that will help someone live a self-directed life. MOUD is not effective because it doesn't immediately end drug addiction. This is another really big one that I hear pretty often. MOUD is not meant to cure opioid use disorder or an addiction, right? Addiction, again, is a chronic illness, impacts individuals for their entire lifetime. Thinking back to the why, thinking about trauma, thinking about the adverse childhood experiences, thinking about the reasons why individuals engage in substances. Life doesn't necessarily get any easier, especially as we age. And so living with these disorders is a lifelong journey. We know that the intention of MOUD is not to cure it, but to manage the physiological aspects of a substance use disorder, of an addiction, right? Allowing individuals to focus more on the behavioral therapies, kind of the underlying why. So just as diabetes is not cured by use of insulin, and people with high blood pressure, they'll often continue taking medication for many years. Like people with an opioid use disorder, people with a substance use disorder are not cured, but instead well managed by taking MOUD. All right, last one. MOUD is inferior to complete unassisted abstinence. Again, this is really common, especially in a lot of the 12-step groups and things like that. I'd like to point out that like many people are able to dispense or quit using opioids on their own and through treatment, but oftentimes go through many dangerous cycles of return to use and recovery, recurrence of use and recovery. MOUD can make that recovery process significantly safer. It's saved many lives by reducing and preventing death from overdose. Substance use disorders, they can be treated and managed with medication and counseling, much like any other medical condition. We know that it's more effective than other treatment approaches that focus on complete unassisted abstinence. We see that abstinence-based programs often demonize any sort of return to use or recurrence, which make individuals feel even more like failures, right? Reinforcing that internalized stigma, and that just perpetuates the stigma surrounding substance use disorders as it is. Any thoughts? Rachel, I have one last little bit and then I'm done, but wanted to open it
Go
up.
for it.
Yeah. Okay. All right. So very last bit is defining recovery. So I usually ask how people define recovery. Spoiler alert, everyone has a different definition, right? Everyone that is engaging in these trainings has a different definition of how they personally define recovery. And then I like to talk about how we all have different definitions of recovery. I bet our patients and clients also have a definition of recovery that they like to use. So thinking about that, this is my personal definition. I view recovery as a process of change through which individuals improve their health and wellness. They are able to live a self-directed life and they strive to reach their full potential, whatever that means, right? Notice I don't have anything in here about, abstinent, sobriety, things like that. It's about individuals achieving their full potential, living a self-directed life. That's why I think it's important to talk to patients, clients about like, what does your recovery journey look like? What are your goals? What are your intentions in entering into treatment? So common elements of recovery that I like to highlight. When we treat addiction as a chronic disease, we know that it can enter a stage of remission, right? Understanding that complete abstinence from all substance use is not a realistic goal for everybody. Understanding that recovery is a lifelong journey. It's going to involve cycles of recurrence and remission, and not demonizing someone for having those cycles. And thinking about people as an entire person, right? Individuals are so much more than their diagnosis. There's so much more beyond a simple substance use behaviors and patterns, right? There is a complex human that's experiencing these things. So I would be remiss if I didn't touch on recurrence abuse. I've kind of mentioned it here and there. So this is an expected part of the recovery process, right? How this is framed, though, when we're interacting with our patients and clients is really, really important. Obviously, if we're framing it as a failure, that's going to be really demoralizing. It can reinforce that internalized stigma. And, having someone return to substance use does not mean that they're a moral failing or a lost cause. It gives us an opportunity as the healthcare providers to think about a treatment option, a new treatment option, right? We know that no one size treatment fits all. Thinking about our words, again, not using the word relapse, thinking about a more less value-laden terms. And then it gives us an opportunity to think about treatment recommendations, treatment plan that's based on the patient concerns, again, that whole person wellness, just as when treating any other chronic illness. So if someone's unable to maintain recovery with the treatment plan that they're on, they may need a referral to a more intensive treatment or additional recovery supports. So that being said, I did want to toss out some community resources. Utah Naloxone is great. They focus on end user training and they provide kits to anyone who completes the training. They also have Andy's. It's a wellness center that offers services to assist folks into being as healthy as possible. UtahNaloxone.org. They're wonderful. And then for any clients, there's these medication disposal kiosks. University of Utah, there's 12 convenient locations. They're great for expired prescriptions, unused medications, controlled substances, October 28th was a big drug take back day. But these, 12 locations, they're just around the valley. They're open all the time. They're like boxes that you can drop things in. So if you take nothing from me rambling at you for 30 minutes, very quickly, I hope that these are the points. If you take nothing but these, I'm good with that. Stigma. It can be internal or external. Either way, we know that it has measurable negative impacts on our clients' health. We have hopefully some strategies for recognizing and avoiding stigma, knowing that thinking about the language that we're using, performing a language audit, increasing awareness of nonverbal communication, visual portrayals, things like that, really an important first step. Thinking about recovery as a process of pursuing health and wellness rather than a destination defined solely by abstinence is really important. Questions, concerns, please let me know. Rachel, you have my email. I encourage people to reach out. Again, usually this takes about an hour. There's a lot of discussion. Just skip right through it. I have all the references if you guys are interested. I don't know how to stop sharing. Here we are.
Thank you so much, Taylor. I think if people want, we have time for one question. If not, I'll be putting Taylor's email in the chat. And since
I'll go.
Oh, go for it, Seth.
Well, first of all, thank you. I thought that was a great presentation. I know you were on hyper speed there, but I see your colleagues in the background there are children.
Yeah, that's Fred.
There's another one too, I saw.
Yeah, that's Finn. I have a Finn and a Fred.
I find this really inspiring. I just think about kind of presentations that I saw maybe 5 years ago, 6 years ago, and just how much progress has been made. It's just extraordinary. And to me, it's like a radical worldview shift on issues around substance use disorders and serious mental illness and mental health challenges. Yeah. So I felt really appreciative. The question I would have for you is, where do you give this presentation? Like what kind of groups have you given this to, and where do you seek to give this presentation? Yeah,
that's a wonderful question. Thank you for the feedback. If there are spaces that you feel like I missed out on, or things in this training that would be beneficial to add in, I know that harm reduction is something that I'd like to add in here as well. I feel there's a lot of stigma surrounding that, or myths and misconceptions. I have given this training. I gave it at the Utah Fall Conference in St. George. I give it to various groups, people in healthcare administration. I used to work at the University of Pittsburgh prior to my stint here at the Department of Health and Human Services at a program evaluation and research unit. I gave this across the state of Pennsylvania, West Virginia, Virginia, Ohio, that type of thing. Wow. Really, if there's a space, I've worked with self-help groups. I've worked with individuals in active recovery and long-term recovery, peers. I feel it's an applicable training for anybody and everybody that is remotely in this space. I've given it to correctional officers, police departments, things like that, first responders. Cool. Yeah, if there are spaces that this would be valuable, happy to come and give it in person. Like I said, it's usually about 45 minutes to an hour. I feel like I just zipped through it. So sorry, I kind of talked at you. It's not usually my style, but hopefully there were some positive takeaways.
Many positive takeaways.
Thanks, yeah, I found it very informative and inspiring both.
Thank you. I appreciate that.